Great. And so there is quite a bit of content here. I might be going quickly through portions of this, but I think it does make sense for people to ask questions as we're going, just to try and make sure that if I'm saying anything that's not clear or it needs any more explanation, that we can get to those things while I'm still talking about a topic. So first, let me just introduce this with setting some expectations. So I went back and I looked. This is actually a version of a lecture that I've given since 2015. I've probably given at least once a year, although it seems like every time I do it, I change the content somewhat. Generally, what I would say is that a lot of the things I talk about here are fairly dense. And so I wouldn't expect anyone, this is certainly not something that I learned in an hour, and I don't think it's something that I'd expect anyone else to learn in an hour. If this is something that you're interested in, it's relevant to your work, I think it's really advisable to go back and rewatch this lecture after we release it, and to the best of your ability to try and research this further. These are topics that I would say aren't really neatly covered in any one single textbook or things like that. I've had to put a lot of this together from a whole variety of sources, including my own personal experience, but I think a lot of this is really valuable both to research and just understanding healthcare system function and how that translates into data and a lot of the research we do using that data. And again, if it's not clear, I do want to emphasize, even though I spend the majority of this talking about healthcare system function, I think the goal here is really to use that to better understand healthcare data. That's what this whole series of lectures will be about, understanding health function and how that becomes the data that we use. I guess another piece that is worth talking about is, from my own personal experience, I think it's much easier to understand many of these topics the closer you are to actual healthcare delivery. For those of us that are technical or work purely on, say, data and database types of sides, I think a lot of these things make less sense until you are actually somewhat more exposed to what's actually happening clinically and from an operations perspective in healthcare. If you're not in any sort of actual clinical facing role, I think it's really recommendable to go out and shadow and have discussions and try and get some exposure to the actual in-person parts of these things to supplement just the kind of theoretical knowledge that we're talking about. And the final caveat that I'll give is that, while I would describe what I'm talking about here as being, really representative of the plurality, maybe even the majority of healthcare system function, U.S. healthcare in particular is full of exceptions and outliers, right? So I am not going to get into the really true detailed nitty-gritty of things like reimbursement mechanisms for dual eligible patients, who have exhausted Medicaid days and are at the point of novel funding mechanisms for home hospice and things like that. But what I will talk about is the function that I think really governs and defines the way healthcare is delivered fundamentally for 80+% of the care that happens in the US. So generally, I would say this is my visual representation of the US healthcare system. It is complex. It is extremely convoluted. We continually add more and more complex and nonsensical pieces to it. And just generally, it is a fairly inefficient system of delivering the care that we intend to deliver to people. And I would say even more sort of exacerbating this is our reaction to really this sort of complex system, I would say, has been to take specific roles and tunnel it down so that we have, in this very large, expansive, and overwhelmingly complex system, we have a tendency to focus on silos, right? So clinical care becomes a very deep silo, and we expect people to focus in significant degrees on extreme, depth just in that one specific area. Same thing with operations, right? Simply the way that healthcare is delivered and the way that it's run and reimbursed is so complex that typically we have people that focus down just in the microcosm of their sort of one specific area of operations. And I think we do the same thing in research. And generally, in the US, healthcare is so complex that the necessity is to generate these sort of tunnel vision silos where we focus to a deep extent in our sort of core areas. And as a result, we really lose focus of what is the larger picture, how do the things that we work on really interact holistically with all the other parts, how are those parts connected to even further downstream parts. And it's very hard to get back and to pull back and to sort of see and understand the entire system from those silos that many of us are living in. And I would say we really do this in healthcare data also. So for those of us that work, really extensively in healthcare data and do research, I would say typically we kind of have research careers that live in a sort of siloed bucket of healthcare data, whether that's claims or whether that's EHR, or whether that's prospective data, like clinical trials data, or one of these, what I would call sort of claims derivative subsets of data like discharge or administrative data, right? So we tend to focus really extensively and deeply on our specific area and gain huge amounts of expertise, again, without sort of understanding fully how do these things relate to any of these other data sets that are happening, and then how do these data sets relate back to the health system function. Broadly, though, at least from a retrospective standpoint, so again, I'm going to say prospective data is really its entire own thing. It is, not handled the same way as retrospective data. But from a retrospective data standpoint, really all of that data is governed by healthcare system function. So fundamentally, regardless of which data silo you tend to live in, if you understand the fundamental healthcare system function, you really have a incredibly broad, valuable basis with which to understand the subsequent funnel of data that comes from the healthcare system, right? So EHR sort of being the first and sort of deepest, but then claims coming from that. And then again, these sort of claims derivative data sets subsequent to that. So if you fundamentally understand the system function, you're really going to have significantly deeper insight into all of these things that come subsequent to that, even if it's not necessarily the data area that you work in or that you focus on. So just to sort of jump immediately into the depth of this, this is the generalized healthcare system processes that I've been talking about. This goes back to work that I did probably 15 years ago, and this is even based on system flow pre-Epic at UNC. Really trying to flow chart out the flow of a patient, first touching the healthcare system, moving through these various decisions and system actions, and touching all of these various IT systems where the clinical care is documented and data is derived from this. So for those of us that have worked here a long time, you'll see some of our old favorite greatest hits like T-System and CPA and CPM and WebSys. But we're going to start somewhere simpler than this. So really, fundamentally, when I talk about healthcare system function, the general process that I'm talking about is this sort of universal generally four-step process of patient comes into some sort of care provisioning area, whether that's inpatient, outpatient, et cetera. Clinical treatment happens, whatever that is. It could be intensive, it could be non-intensive. There's a lot of data that gets created to record or document that clinical work. Then there is some sort of process to distill that whole body of clinical data that's generated into some sort of structured, standardized form, focused on communicating the care that was delivered for reimbursement. And then the provider, broadly, whether that's a single physician's office, or whether that's a gigantic hospital as part of a huge healthcare system, that provider then sends this structured payer, the provider then sends the payer this distilled, structured data set to communicate the care that was delivered, to justify it, and to request reimbursement for all of that care. So at the very highest possible level, this is the process that is pretty much universally happening, regardless of care delivery site or the care that's happening, to document and record all of the clinical work that's happening, and then to generate all of the data that we subsequently wind up using, both from an EHR and a claims data perspective. So now we're going to spend a little bit of time walking through this process and adding in additional layers of detail as we move forward. So in more detail, taking each of these pieces by step by step, and thinking about some of the more details happening at each piece. So this part of the process where I say data created to record or document the clinical work, this is where the EHR lives. So, typically, in an outpatient setting, this would be some sort of, outpatient component of either a large EHR system, so that could be Epic or Cerner or Allscripts, or maybe it's a very outpatient focused EHR, right? So something like Athena or, Open Notes or other really doctor's office focused EHR systems. But this is, those systems where this portion of the work is happening. And I think of this as really two pieces. There's sort of an active data recording piece. So this is where clinical care providers are writing notes, they're submitting orders, nurses might be charting. But then there's also more of a system level piece where the actual EHR application is automatically triggering things that are generating data and metadata. So these are things like ADT, the admitting, discharging, transferring system. Pretty much every system is generating notes on the fly. And all of these things together are cumulatively generating all of the notes, all of the clinical and operational data to document comprehensively the care that is being delivered, right? So this is the deepest view into what is going on with a patient, what is the care that's being delivered, and what is happening. So next, this very voluminous body of information has to begin to get distilled into some other format that is suitable for really distilling all of that information down to something very minimal to subsequently generate what is practically a bill, right? A claim that would be submitted to a payer for reimbursement. And that process typically happens through a couple of ways. One is through coding, right? So that's an active process, both on an inpatient and an outpatient side, where this whole body of information is put in front of a human coder whose job is just to assign discrete data codes, right? So ICDs or HCPCS, to really distill all of this information down into just a very minimal piece of sort of transactional information that will ultimately go onto the claim to be recorded. And another way, in some settings, is there are actual pick lists. So for instance, in doctors' offices and physicians' offices, sometimes this is done through something like an encounter sheet where there's literally a piece of paper or something else where as a care provider is providing care, they're literally just writing down the codes for the actions that they take and maybe the diagnoses to justify those codes, right? But so there's this significant translation in this step where, very voluminous, oftentimes free text care documentation is being translated into a very codified set of data that forms one portion of the outgoing bill. And then subsequently, this data goes on to these standardized forms, a UB04 and a CMS 1500. We'll talk about these a little bit more in detail later on. But it's really each of these, both with the coded data as well as some other systematic data, administrative data, so things like demographics on the patient, insurance information, but those plus the coded information go onto these forms and then go out to payers as the actual reimbursable claim. And so thinking about this more from the less sort of the system and process level and more from the actual data level, at each of these steps, what's happening here, right? So you have EHR or clinical data happening at the first step. You have the coding process happening, but then generally after the coding, you're generating what we would think of as the internal claim. So this is the body of information, the clinical data that a provider is generating and intending to send out to the payer. When the payer gets those claims, they process them, turn around and can send them back. This is what we would tend to think of as full-blown claims data. So typically this will have the actual reimbursement information on it, likely even with the payments received, right? So differentiating here between the internal claim that goes out to the payer versus the full claims data that can come back from the payer. And then also thinking about the pieces that go into this, right? So we talked about this briefly in the previous level, right? But lots of things live at that EHR level. So ADT, notes, orders, problem list, diagnoses, procedures. And then at the coding level, everything is being distilled down into really a small number of codified terminologies. So typically, it's pretty much just going to be ICD diagnosis codes on the on another side that we'll talk about in more detail. It might be HCPCS level or CPT level. And then those pieces are combined to generate the internal claim. And then the internal claim comes back from the payer, with some more cost information. And depending on your claims feed, the real difference here can be that you, as a body of claims knowledge, you can actually have the claims data supplemented with claims from other providers, not just a single provider. And so something to think about more from a theoretical level here is really sort of what's happening in this distillation process. So at times when I try and talk to students about this, I try and think about this almost as an extended version of telephone. So at the beginning of this, you really have the empirical truth. So a patient might have something straightforward or not straightforward, right? So take something like chronic fatigue syndrome. This is something that in the data science lab we've thought about to some degree in relationship to things like long COVID. But say the empirical truth is that a patient has chronic fatigue syndrome or myalgic encephalitis. And then you really have this extended game of telephone where they work they encounter with a provider, and then the provider is running tests, right? That empirical truth is sort of being interpreted by the provider and the actions that the provider is taking. And so that empirical truth is then ideally represented in the EHR data pretty deeply and broadly, right? So we have a lot of information and context at the EHR level, ideally about what the empirical truth is. And then at the internal claim level, all of that is being distilled down into a very a sort of concentrated layer of typically just ICD codes and maybe HCPCS and CPT codes. And then, at each level, you're sort of reducing the sort of the depth and the context of the data that you're looking at for a patient. And that's where, on things that are potentially very complicated, by the time you're getting to just the claims data level, it can be very, I'm trying to pick my words carefully. It can be difficult to assess what is truly going on with the patient at the empirical level by the time you're getting to just the very distilled ICD level in the claims, or even, the subset of the claims, right? If you're working with sort of the subset that would just be the discharge data or just the administrative data. And the more, I would say, complex and nuanced a patient situation is, the more that this can become really relevant. So, things where we've thought about this a lot are particularly, things that over time have not even had ICD codes. So things like long COVID, chronic fatigue, myalgic encephalitis. But this comes up a lot in diabetes also. So while at the empirical level, it might be very obvious whether someone has type 1 versus type 2 diabetes. By the time you get to the claims data level and all you have are diagnosis codes, even without the context of, provider interpretation or concern or context, or, the specific labs that are being ordered, it can be very difficult to tell, when someone has an abundance of both type 1 and type 2 diabetes codes in the claims data level, and that's the only information you have. It can be fairly challenging to tell what the empirical truth of a patient is. And so this is, something that I think it's important to think about depending on the data layer you're working at and recognizing where you are in this sort of health function level and the data sort of relative to that health function level. And so we've spent, some amount of time really focused on thinking about the most basic sort of health function and health system function and the processes, the standardized processes that happen. The truth, though, is while those processes are the same, the processes are sort of different depending on the type of care that's being provided. So, even if that clinical treatment happening, data, being generated to document that work, that data being distilled into a standardized level, and then that distilled data going out to be, outgoing claim that goes to a provider for reimbursement. The actuality is, we have sort of different systems that same process happens in to document and record different types of care. And I'm going to talk about this in quite a bit more detail through a variety of subsequent slides here. So the question becomes, up to this point, we've just sort of been talking about care generally and health system function generally. But the truth is we really differentiate between what I'll colloquially refer to as sort of clinic-based care versus hospital-based care. More specifically, we would think of this as facility and professional-based care, right? So even though these health system functions are essentially the same, that kind of stepwise process we've been talking about, the US actually has two discrete systems, the facility system and the professional system. And so this is a major takeaway, right? So if that overall kind of 4 to 5 step process is a really core portion of this, the other piece is that there's a facility system and a professional system of care, and that process is repeated in each of these systems. And this is really explanatory for a bunch of fundamental things. So for instance, like why, as a healthcare patient in the US, why do you get multiple bills for one body of care, right? Why do we have multiple parts of Medicare, right? Why are there different portions of insurance that seem to function around different types of care? It is for this reason, right? Fundamentally, for, again, a plurality or majority of care, we essentially have two systems to handle two different types of care. and this is, best represented by these two forms that I referred to before, the UB04 and the CMS 1500, right? So depending on the type of care you're receiving, your outgoing claim is going to be sent to be reimbursed through one of these two systems on one of these two standardized forms. So if it is, care delivered by a facility, and we'll talk more about what a facility is and why this system, why this differentiation exists, it's going to go out on a UB04 form, right? So that's one set of standardized information and data that's going out, essentially one set of claims and codes that are specifically used to go on that UB04 form, getting derived from your body of EHR and clinical information, versus the CMS 1500, which is a different form with a different set of essentially codified data that forms your claim going out. Question, yes?
What was the difference between the red box and yellow and green box?
Yeah, so good question. So this is, the color coding actually goes back to be honest, an older slide where I pegged it to this diagram. But I place a lot less emphasis on this diagram now in modern slides. So now I don't really truly, relate those boxes back to that. But what it is mainly intended to represent is that we have essentially this same process, but happening for fairly different, distinct, systems or system purposes, depending on the care location. So this is where I get into, there is a truly, quote unquote, like outpatient professional side. That's the blue box here. And then when you're on the facility side, you have, the professional side again, but because that is sort of going out through a facility, it winds up looking slightly different than the truly outpatient side. That's the green box here. And both of those are completely different than the entire system of the red, which is the facility system. To be honest, what I should do is probably update the professional to be more like two versions of the same color, right? Like two versions of blue as opposed to three totally discrete colors. But does that answer? The question was the meaningful or the significance of the different colors of the boxes on this slide. Okay. Yes, another question?
I have a related follow-up question.
Yeah.
So in regards to that dichotomy, how do you anticipate that site neutrality is going to increasingly eliminate that sort of middle column, if you will? Or is it going to become, all right, this is clinical treatment related to ambulatory care versus clinical treatment related to inpatient or hospital care?
Let me state that back and see if this captures what you're getting at. I mean, are you asking about sort of the fundamental like reimbursement mechanisms depending on like the site of the provisioning of care?
Or just in terms of data, like
Yeah.
do you think it's going to be consolidated or it's just going to stay the same and really it's just the reimbursement doesn't change depending on whether or not you have a facility fee? Like, do you see it fundamentally changing how facility data is reported? I mean, I realize it's still in its infancy and it's just starting with, like, for example, infusion therapy, but eventually the goal is to completely eliminate the facility fee.
Well, and so again, you're referencing the facility fee specifically. And so I would say, again, this is where there might be portions of the system that can change without the overall system changing. And so this is where, if I go all the way back to the beginning of this, right, like I think the way I would describe this is, right, anytime we make changes to the overall system, I feel like we never streamline or take things away for the most part. We typically add like incremental, small, very like policy wonkish types of things, right? Like it's, we're not going to remove the rocket. We're going to change the type of rocket, right? Or very slightly modify it in a fairly complicated way to try and encourage some type of behavior. And so I think, you're referring to the facility fee portion specifically. Like, is your question more, do I think the facility data will change as we change portions of, say, like the facility process and the facility reimbursement mechanism in the future specifically?
Yeah, I mean, it seems like it would obviate the need for having to report that data, which therefore would maybe save costs.
This is speculation, right? So like this is a futurescape kind of question. I should also say it's fairly, this is a bit of a rabbit hole to go down. So if like this is not, I would say this is slightly beyond the scope of today's talk. But what I would quickly say is, I don't think so. I think what we have seen traditionally is that we change very small, again, portions of systems, or maybe even, very large portions of systems, but in very specific kind of, again, policy wonkish kinds of ways, without largely affecting, the overall big picture system process or the way the data flows from it, right? So I think one of the biggest changes that I could think of was, and again, this is more of a next lecture topic than this topic, but so from facility, like moving facility from fee for service to prospective payment, right? Like fairly large fundamental change that does affect the data. I think it would take something at that scale to really affect the facility level data again. I think short of something at that level, I think facility data will continue to exist the way it does. But again, this is sort of speculation. Okay, so I think I was here. And now moving on to sort of some fundamental explanation. I feel like when people are first learning about this concept of like, why do we have multiple systems of data and reimbursement in the US? Like, why does this exist? Like, why is, why? Particularly if you're used to thinking of the US as being like one overall healthcare system. I feel like it's often extremely helpful to understand like what is actually happening here? Like, why do we have these? So basically, there are these two fundamental high frequency care delivery systems that they handle like very different parts of the US healthcare system, right? So the professional system is built to handle care delivery from LIPs, licensed independent practitioners. LIPs are care providers that basically can provide care and bill for it independently. So these are things like MDs, DOs, DDSs, podiatrists, clinical psychologists, optometrists, but also APPs, so PAs, nurse practitioners, CRNAs, right? So these are all people that can provide care and bill for their care. Noticeably, there are many people that we think of as care providers that are not LIPs, right? Nursing being a major one. So like a standard nurse who is not a nurse practitioner or some other advanced credentialed nurse cannot generate their own bills. This has a really significant ramification for like, how the places that employ nurses get paid or how they get paid for the labor that nurses provide. And this is also why, for instance, you don't see, I would say, general, what we think of as like floor level nursing or non-advanced care nursing in professional system data, right? So the professional system exists to basically document and reimburse LIPs. And again, this is why in claims, for instance, like you see data from certain types of providers and not other types of care providers. Now, the facility system, obviously this handles care from facilities. What are facilities? Facilities over time has been this really umbrella term, and I should also say facility is sometimes interchangeably used with institutional, right? So the institutional system, the facility system are essentially the same thing. But facilities are hospitals, ambulatory surgical centers, dialysis centers, skilled nursing facilities, LTACs, also freestanding imaging, freestanding ED. These are facilities that are paid through the facility system. Now, noticeably, and we'll talk in more detail on this, the facility system does not exist to pay for professionals, right? So LIPs can work in facilities, but the facility system generally does not pay the LIPs that work in the facility. We'll talk about this in more detail, okay? But this is fundamental. Now, again, why does this exist, right? So this goes all the way back to how healthcare started, right? Like early 20th century. So historically, the job of being a physician was a small business, right? Like physicians had small practices in the community, and they were focused on non-intensive care delivery that they could do locally in the community. Hospitals, over time, as this need sort of began, were separate locations, i.e. businesses, that existed for acute, more intensive care that physicians could not provide just locally in the community, right? So think of surgery, right? Like you did not really want to provide surgery or high acuity intensive care in your like small community practice. You wanted to go somewhere that had the resourcing, both in terms of equipment and staff to take care of those patients. But critically, the way this worked was that hospitals were basically just the locations where all of this other stuff existed. The community physicians had to admit their patients to that hospital, and then they physically went to the hospital to take care of them there, right? So this is where you get this idea of like you have these different care businesses, but the physician is not a portion, they're not part of the hospital, right? Like they're just showing up to take care of the hospital. They're showing up to take care of the patient in that other hospital location. I will also say this has become fairly different than how healthcare works today. Like maybe still in some communities and community hospitals, you have like, you know, community physicians with admitting privileges to hospitals, but like I would say for the most part, particularly for large and academic hospitals and facilities, like this is not the business model that we have today. Okay, so now thinking about this sort of like historically small business, community focused model to what was a hospital, okay? Hospitals, like basically historically have not been, or at least significantly less, small businesses, right? Their business is large with intensive capital and labor costs, right? So like they have a large real estate footprint, they have a large building footprint, and a large facility and maintenance footprint, and a large utility footprint. Not to mention, like they have to build and maintain specialized areas like imaging and operating rooms. So I think people also tend not to think about this, but hospitals also have to do all of these like super intensive, high frequency things that are totally unrelated to care provisioning, like providing residential room and board and food to people, right? So when I worked in the hospital and the healthcare system, there was an executive there on the operational side who had this great quote, and he said, you know, people don't think about this, but in most communities, the hospital is actually, you know, many things, right? It's the largest employer, it's the largest this, but it's also the largest, highest frequency restaurant in that community. It is the largest, highest frequency hotel in that community. It's the largest, highest frequency cleaning service, right? So like it is a business that does all of these really large capital intensive things related to care, in addition to all of these things related to just housing people in a place and maintaining them with food and cleaning, all of these other things, right? This is a radically different business, both in terms of cost and execution and operations than the community physician, right, historically. And what this means is that you need a radically different mechanism to pay things like hospitals that have all of these other costs and business models than the community physician, right? So this is where the facility reimbursement system grew from, right? So over time, we had hospitals and we had these health systems that kind of diverged in how they received data and how they paid out for the respective costs associated with the providing of that care. Okay, so let's see. I think two of the other takeaways here are, so one, in thinking about this facility model, and this touches on the question on facility fee only tangentially, but while the facility model sort of existed fundamentally to pay for this very different business model with different expenses and cost structure, it has been, I would say, successfully extended and in modern times exploited in very creative ways, right? So at this point, we no longer have things as clean as, you have a community clinic, that only gets paid on the professional system, and you only have giant facility hospitals that only get paid on the facility system, right? We have businesses within businesses within businesses with, lots of different ways of managing this, right? So notably, the facility system pays more than the professional system. And so what that has meant is that sometimes, for good reasons, facilities can own clinics or other things, and then those clinics can get paid through the facility system, right? So an example of this is you have a very large hospital, and it makes sense to build a clinic inside the hospital, which is then a facility clinic and can get paid through the facility system at a much higher rate than a freestanding clinic. You also have things and business relationships where you have freestanding outpatient clinics that are only contractually owned by a facility, and yet simply by virtue of that relationship, they can bill as a facility, even though they don't have the same cost structure as a clinic that perhaps exists within a facility. This is where I say there has been significant financial engineering to exploit sometimes, and again, to be clear, sometimes this is justified and sometimes it has been exploited to really utilize the business model in the modern healthcare system. So I would say I would peg the social transformation of American medicine. Like, if this is interesting to you, the social transformation of American medicine is like a fundamental book on this topic of the development and evolution of the American healthcare system from, like the 19th century onward, including a lot of the things we're talking about, the formation and organization of insurance, the development of these multiple systems, the business relationships, but very well-known book in this area, and I would recommend it on these topics. So here is more of like a visual example of, what does this mean today, right? Like the businesses within businesses within businesses, right? So, well, I can present this as sort of cleanly being we have a professional system and we have a facility system. The reality is we have incredibly convoluted and complex business relationships that govern the care provisioning and the operations today, right? So even in a modern, very large healthcare system, we typically have the providers who are getting paid through a professional system, but that are actually employees of the hospital or the healthcare system, right? And then similarly, oftentimes the healthcare system will own many different facilities under an umbrella that are sort of interrelated pieces, with convoluted business relationships. And so this is where I say, again, through necessity, the understanding of the operations of many of these pieces has become a very deep and complex tunnel to go down into. And so while it is necessary and fundamental to understand we have a professional system, we have a facility system, the actual triaging and sort of, untying the Gordian knot of some of these relationships can be very non-trivial and convoluted. And yes, question?
You might get to this, in which case just tell us that.
Yeah.
You're sort of mentioning that the paying is very different for the facility system and higher. Is it generally like the same payer and they just have this internal distinction of, oh, you're a facility, we'll pay the higher rate for facilities? Like, is it an insurance company is the payer in making these decisions, or multiple different kinds of payers?
Yeah, we can talk about this more. The question is related to payers. Like, are there different types of payers? How do the payers actually sort of execute on professional versus facility? I plan on talking about this more in the next lecture, which is more focused on like sort of typical reimbursement actions. But the short answer is that yes, so payers in America are typically insurance, but now we have essentially two different types of payers, right? We have government and non-government. And on the government side, we basically have Medicare and Medicaid. And on the non-government side, we have every sort of private insurance flavor you can imagine, whether that's the Blue Crosses and Blue Shields, all the way out to the truly corporate for-profit companies like United Health. But yes, so internally, all of these companies basically have separate systems that execute on the different claims that they receive, whether they're professional or whether they're facility, and they have their own processes to go through and review and adjudicate all of that information. But now, interestingly, and this is something, again, we'll talk about, oftentimes Medicare is really the payer that sets the expectation of how things are going to happen. So for instance, Medicare was really fundamentally the payer that originally decided we are going to stop paying facilities on fee-for-service. We are going to pay them on prospective payment. And the result of that often, when Medicare makes these decisions, is that you see the non-government payers sort of fall in line behind this and say, okay, like now we're going to accept prospective payment for the facility also. This is why Medicare policy and Medicare decision-making is often such a fundamentally huge part of the American healthcare system, right? Decisions and policies that get put into place for Medicare many times become the expectations and policies that are also put into place for commercial payers. So again, coming back to this slide, in theory, this begins to make more sense at this point, or at least maybe you begin to have more insight and clarity into this, right? So you have this truly outpatient sort of professional side, right? Where historically you think of this as physician in one outpatient clinic providing treatment, they're generating documentation data to document care. That's becoming, discrete standardized code, codes that go onto, this very professional facing side that goes into a payer who's evaluating it as a professional claim. And then on the facility side, what's happening is there's a facility side of things and a professional side of things, right? So the facility side is really generating the claims to generate the reimbursement for just the facility side of care. But then there is a simultaneous professional piece happening on the facility side to document and bill for whatever the professional work happening in the facility is. And I think this becomes more clear from this slide where I try to really draw this out in diagrammatic detail, right? So think about a patient who goes to the hospital, right? So many things can happen during a single hospital stay. So say they're admitted through the emergency room. Now, even though the emergency room care from a structural standpoint is probably going to get paid for through the facility bill, the time and effort of, say, the physician in the emergency room is going to generate typically a professional bill. Now, say they're admitted to the hospital through the emergency room, all of that care for all of the days in the hospital, all of that is going on to the one facility bill for that hospital stay. And now say they need surgery. Okay, so again, the structural fees associated with the operating room and the equipment and the supplies, that is all getting recorded and would ultimately get paid out through the facility side of things. But the labor of the surgeon is going to generate a new professional bill that is distinct from any of the other professional bills, but also distinct from the facility side of things. And now same thing, say that they require imaging. So similarly, at a minimum, you would expect to see a new professional bill generated by the radiologist. But now, interestingly, this is where the business relationships can come into things, right? So say they receive imaging, but say that it's by a freestanding imaging center, or say it's even by an imaging center that is a separate business outside of the actual business of the hospital. That means that potentially even a new facility bill can get generated. This is all going to the complexity of how are the businesses structured and how are they related. And how does that generate both the clinical data and then subsequently the reimbursement claims, which become the claims data for all of these patients. And I'm going to plug my paper here. So this is something that a couple of years ago within N3C, me and others spent a lot of time working on from the really network data standpoint, right? So hospitals have different ways of doing this and recording this data. And it's, one level of effort and complexity to sort of look at this for hospitalizations within one site. But within the N3C repository, we have somewhere on the order of like 80 to 90 sites. And many of these hospitals are actually recording these types of transactions somewhat differently. And so when you try and look at, say, hospital level data across 80 to 90 sites, what you find is that you have huge heterogeneity in how all of these hospitals are recording things, right? Some send their hospital data or their facility data as one sort of chunk of a multi-day stay. Others send, multiple one-day stays. And so we have a methods paper here on a lot of work that we did really looking at how do you characterize the heterogeneity of this, and then how do you rectify it post hoc. So if this is an interesting topic, there's plenty more to get into, and I'd point to that paper as a first stop for you to look at. So I'm going to stop there. This is quite a bit of dense information to get through, and we've covered a lot of topics. As I've alluded to, next time I would plan on getting much more into sort of the reimbursement level details, as well as the data related to that, right? So both at the dollar level, as well as the data level, right? So introducing things like the DRG, how the DRG is related, what the DRG actually tells us, the differences between fee-for-service and prospective payment. And then ultimately, all of that will then lead us up into another lecture that our data science lab research scholar, Dr. Dave Friedlander, will give really on payment mechanisms from a more advanced way, right? So really looking at what is happening in payment models today and innovation in payment models, and also the extension out into a lot of the trends we're looking at in terms of things like value-based purchasing relative to traditional payment mechanisms and reimbursement mechanisms. So with that, let me stop and see what questions we might have either in the room or on the Zoom.
How will facility and professional bills show up in claims data for outpatient visits?
So that would be typically just a fundamental part of the claims data. So I guess the first piece is typically you wouldn't expect outpatient visits to show up in sort of facility claims data at all, unless it were something like an ambulatory surgical center or maybe possibly some sort of like outpatient hospital visit. But so typically, I guess the longer answer is it depends on your source of claims data. So for instance, in Medicare, you typically see facility data coming through specific files from Medicare. So typically these are the files coming from Medicare Part A, which sometimes they call the outpatient, the inpatient or the hospital file. And you see the professional typically coming through the Medicare Part B file, which is oftentimes called the carrier file. In commercial claims, it really depends on how the commercial payer has their claims data structured. So sometimes they'll have a specific quote unquote inpatient file of claims data, which will be either their facility data or a subset of their facility data. And then other times, they will simply send all of their claims data lumped back together, and it will be up to the person looking at it to be able to differentiate what are the specific data elements that exist in, say, facility data versus non-facility data to kind of differentiate. So I guess it's worth noting that, even though the outgoing claims data is standardized onto these forms. Everyone has to submit things now they're electronic, but an electronic, standard based on the UB04 form or the CMS 1500. It's very rare to get claims data back from commercial payers in a very standardized format. Typically, you're getting the standardized data, but with some modification or in some sort of architectural structure, that's different from another payer, like I'm saying, where you get one file or multiple files, or different data or metadata that they've appended on. So it's, even in claims data, which is more standardized than EHR, it can take quite a bit of work looking at the claims data to sort of differentiate, like what is, for instance, the inpatient claims data versus what is the outpatient.
And then there's somebody that wants to just have us clarify that typically when you're requesting EHR data for research, you don't get claims data. That's a different type of data source, data warehouse, if you will.
All right. I don't see any other, oh yeah, question in the back?
So a little bit about the EHR side and the coding of information.
Mm-hmm.
So like, there's this, if you have an Apple phone, you can connect it to your provider and see your health records, and it's pretty cool. You can see it come through even in FHIR format. And the codes in there, I've noticed, are always in SNOMED.
Yeah.
Is that like an increasing standard that's actually used in clinical care, or is there some sort of automatic mapping that's happening in between, my phone and the person who entered the data?
Yeah, so the question is, let me rephrase the question. Let me see if this captures it. It's sort of terminology specific. So, and specifically SNOMED, like when does SNOMED happen? And like, why do we see SNOMED in certain places? Specifically, like if we use the EHR connectivity that Apple has, like why does SNOMED show up in there? Yeah, so typically SNOMED, to be fully honest, is not really a very common part of the US health system, like data standard. So the typical parts, and again, this is sort of, it's dependent on the system you're looking at, but you can basically look at, for instance, claims data, and you can tell exactly what's happening often by the terminologies that are contained within it, right? So facility data will have basically ICDs, so ICD diagnosis codes, ICD procedure codes, and a DRG. And that's pretty much it, other than the administrative data in terms of the insurance information and demographics and et cetera. Professional data will typically have CPTs, or which are HCPCS level, I think level 2, and then ICD diagnosis codes that exist to really justify the use of those codes. And oftentimes that's like the extent of what's coming in through there. SNOMED doesn't make it onto any of the outgoing claims information today. And I feel like historically, SNOMED was almost a very physician informaticist kind of terminology, where people were really interested in it from very like sort of taxonomic reasons, and sometimes even more like theoretical reasons, like can we develop a terminology that does everything, right? Like rather than segmenting out pieces of things into different terminologies, can we develop, this one body that can handle everything, which is sort of the, how SNOMED functions, versus in other countries where SNOMED does have more of an actual like function within the healthcare system. Yeah, so my understanding is when we're seeing SNOMED, it's pretty much always the result of some sort of mapping that's happening somewhere. Because it's not, you know, it's not part of the health system function actively that's getting fed into either the professional or facility system of data and reimbursement. And so maybe it's a mapping that's happening, you know, within the provider itself, or maybe it's happening post hoc, you know, like for instance, OMOP, which uses SNOMED as a standard, but all of that translation is happening post hoc, essentially. We're bringing over the source and then it's getting mapped to SNOMED. Yeah, and so I have yet to see, I might not know the most up-to-date information, but I have yet to see anywhere where SNOMED as a terminology is actually part of like the actual health system function, you know, as part of the official recording of data and then transmitting it to a payer for payment and those kinds of things. Yeah. Okay. Thanks everyone for your time. As I've said, next week, or sorry, next month, we'll be focusing more on kind of the extension of this into reimbursement and related data and system flow. And so I'll look forward to seeing everyone there. And within a couple of days, we'll have this recording posted for people to review. Thank you.